Hello, sir. Hi. How are you? Nice to see you after a long time.
Yes, absolutely.
Yeah, good to see you. Wonderful. Yeah.
Great.
I think we're going to go live. So, yeah.
A very good evening, everyone. Welcome to iFocus Online Lecture 239, number 26 in our series from Squint and Paediatric Ophthalmology. Today we have with us Dr. B Venkateswar Rao, sir, from Shreya Eye Care Center, Hyderabad, talking to us on Duane Syndrome, Etiology, Classification, Diagnosis and Management. The chairs for today are Dr. Pradeep Sharma, sir, and Dr. A.K. Amitava, sir. I request Pradeep Sharma, sir, to please welcome our speaker and introduce him to our audience.
Thank you, Dr. Shefali. It's again a pleasure to be with all of the people on the iFocus Online, which is a great initiative started by Dr. Santosh. And today we have Dr. B Venkateswar Rao from Hyderabad and telling us about Duane's retraction syndrome management. He is our colleague from RP Center days way back in 90s. He did his MD from RP Center, AIMS, New Delhi, fellowship in strabismus and neuro-ophthalmology and Dr. Prem Prakash at RP Center, AIMS, and then a post-fellowship in pediatric ophthalmology and strabismus from the Indiana University Medical Center, Indianapolis, USA, with Dr. Helveston. Then he was the past HOD, Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at LVPI, Hyderabad. Currently, he is the director of Shreya Eye Care Center, Hyderabad, which provides cost-effective treatment in the field of strabismus, pediatric diseases, and neuro-ophthalmology. He's a passionate teacher who has delivered lectures in Indian and American universities, many publications to his name in national and international journals, active participation in national and international conferences like the American Academy of Ophthalmology, APOS, and ESA. So we are all eager to listen to Dr. B Venkateswar Rao to tell us about the management diagnosis of Duane's retraction syndrome. Dr. B. Rao.
Yeah. Thank you, Dr. Pradeep Sharma. Thank you, Dr. Shefali, for that introduction. Yeah, so, yeah. Yeah. So, right. So, so I'm going to, that's a very informative series of lectures by the Center for Sight and Dr. Santosh, who started all this. It's very useful to a lot of postgraduates and other people with the continuing medical education. So my topic today is management of Duane syndrome. So let's go into, the features of Duane syndrome. As you all know, Duane syndrome is basically a congenital misinnervation syndrome of the lateral rectus muscle, also classified into CCDS, congenital cranial disinnervation syndromes, and Duane's is one of them. Now, if you look at the clinical features of Duane syndrome, are usually abduction limitation, narrowing of the palpebral fissure on attempted adduction. There is associated globe retraction, and sometimes you can have an upshoot or downshoot. And when you have a primary position deviation in them, the patients tend to develop a face turn or head posture. Now, in essence of the Duane syndrome, usually it's an abnormal or an agenesis of sixth nerve nucleus, and with a sympathizing third nerve sending a twin of it to either the medial rectus and the lateral rectus getting co-innervated. So it's kind of a congenital misinnervation between the third and the sixth nerve, as a result of which, whichever muscle gets more innervation, you tend to develop a deviation into that particular position. Let's say if the lateral rectus gets more innervation from the sixth nerve and a part of it from third nerve, you tend to get an exotropia. And if you get medial rectus more innervated from the third nerve peak, you tend to get esotropia. So you tend to have esotropic Duane, a type 1, or the Huber's classification initially was based on the limitation of eye movements, type 1, type 2, and type 3. The more innervational ones are based on the amount of innervation which is going to either the medial rectus or the lateral rectus, which will tell you whether it's going to be esotropic or an exotropic domain or an orthotropic domain. Now, if you look here in this picture, there are about 4 types of domains. The last one is the synergistic divergence. It's kind of misspelled here. That's the rarest form of the domain. The most common is a type 1, the second is a type 2, and type 3. Now, if you look here, and the type 1, generally the innervation, the medial rectus gets more innervation as a result of the split from the third nerve. So you tend to get esotropia. And in type 2, the lateral rectus tends to get more innervation as opposed to the medial rectus, and the limitation of movement is more into adduction. So you get type 2. And in type 3, you get more or less equal innervation to the lateral and medial. So the eye stays in the primary position, and it's usually orthotropic. Now, coming to the most common ones, the type 1 or the esotropic domain, you have esotropia in the primary position, usually with the patient having a head posture, the face turned towards the affected side. And generally, once you correct the head posture, you have esotropia in the primary position. Usually, the esotropia could be anywhere between 15 prism diopters to 30 to 35 prism diopters. Sometimes you have larger deviations, but most of the times in Duane syndrome, the classic thing is the amount of deviation is not commensurating with the amount of limitation of eye movement. When you have a -4 abduction, you tend to have more ET. You should have more ET like in sixth nerve palsy, but in Duane's, you tend to have lesser ET. And sometimes you have a limitation of eye movement in abduction, but you tend to get exotropia, paradoxical. You should get esotropia, but it's exotropic. That's type 2 Duane. But commonly in the type 1, you have esotropia because of the innervation going to the medial more. And the adduction is usually normal, or sometimes maybe could be mild limitation, but it's near normal usually. The most of it is abduction limitation, which could be anywhere between -3 to -4. And you tend to have a mild to moderate amount of retraction, narrowing of palpebral fissure and retraction. And usually the sensory status, the binocular vision is good with the head posture. And now here's a child with the Duane syndrome. You can see that face turned here. And with the head held straight, fixing with the left eye, you tend to get an ET in the right eye, and limitation of abduction about -4. And you see a little narrowing of palpebral fissure and attempted adduction, but there's not much of a overshoot on attempted adduction. And here is a case of bilateral Duane syndrome. The bilateral Duane syndrome are far less in number, somewhere close to about 10%, but most of it is unilateral ones. And usually, the original classification of Stilling-Turk syndrome, the left eye was more commonly involved, and females used to get more commonly affected in Duane syndrome, which was originally described. Now, coming to the management of Duane syndrome. So, what are the goals of treatment in that? Now, if the patient has a head posture, why the patient is having a head posture? The head posture is because of a primary position deviation. Whenever you have a primary position deviation, there is a compensatory head turn towards the other side or towards the same side, basically in opposite field, to maintain the binocularity. So most of the patients with type 1 Duane syndrome tend to have a face turn to the affected side, and then they maintain binocularity into the other side. Now, once you correct the head posture, you get esotropia in the primary position. So the goal is to improve the head posture. That means to align the eyes in the primary position by doing a surgical procedure, whichever surgical procedure you would opt to. There are various surgical procedures. So we will talk about that in the later slides. Now, other goal of the treatment is basically the overshoot, the upshoot and the downshoot, which are cosmetically disfiguring. Whenever the eye looks into adduction, the eye tends to kind of overshoot, sometimes disappearing under the lid, and is cosmetically disfiguring. So you to kind of eliminate or basically alleviate the overshoots by doing a surgical procedure. And at the same time, sometimes you have a marked retraction of the globe, where the globe tends to kind of pull backwards into the orbit because of co-contraction of both medial and lateral rectors. So severe that it's cosmetically, unacceptable. And where you might have to go, indication for surgery in them to kind of reduce or eliminate the retraction of the globe. Now, another thing which has of late been being propagated, not of late, it's been there for quite a bit, improving the field of binocular single vision. So basically here what we're going to do is we're going to do some procedures to improve the abduction, like for 6-nerve palsy or any paralytic squint. So you want to increase the field of binocular single vision by improving the abduction by doing certain procedures. But at the same time, in this, you should not compromise the other field. So the basic idea is to enlarge the field, but not compromise the field onto the side which was originally was the preferred position. Okay. So these are some of the indications or goals of treatment in Duane syndrome. Now let's go to the esotropic Duane. Now, what are all the various procedures which are available? Okay, the best one initially would be if the goal is to get the head posture corrected. Then the simplest would be to operate the ipsilateral medial rectus. In this case, the left medial rectus to fix the ET in the primary position and also help to reduce markedly or eliminate the face turn. And sometimes if there's a deviation is more, you could actually do the other eye also, the medial rectus recess on the contralateral side, so that it changes the 6th-nerve innervation to the left lateral rectus. So thereby, what happens is it inhibits the left medial rectus not going into contracture. Okay. Now this is basically you want to correct the head turns, and you're happy with that, then this is the best procedure you can go. Now sometimes you could because there is a limitation to the amount of recession you do on the medial rectus in esotropic Duane or unilateral Duane syndrome with esotropia. Typically, you should not recess the medial, beyond 5 millimeters. Sometimes you could go between 5 to 6, but 5 millimeters is ideal because sometimes once you do a larger recession of medial on the affected side, you tend to get a consecutive exotropia, in the sense that the eye turns into XT, and when the co-contracture is there, when the eye is attempting to adduct, the lateral rectus fires, and you tend to get more exotropia as days progress by. So you don't want to recess more than 5 millimeters of medial rectus on the same side. So you share the surgery by doing a larger recession on the other side, like on the unaffected side or on the contralateral medial rectus, which creates again a fixation duress, and that helps inhibit the left medial rectus. Now, there are other procedures which are described like doing a recess-resect procedure, like a left medial rectus recess or a left lateral rectus resect in this eye, in the affected eye, has been proposed by Steve Kraft and colleagues who have done and with good results. But it's been standard teaching says that you don't resect the medial rectus in the affected eye. The reason being that if you resect the medial rectus, you're going to cause more amount of retraction when the eye tends to adduct, and that also can cause severe retraction and upshoots. So that's the reason we were taught that you should not resect the lateral in Duane syndrome. But a few authors have done a small resection, specifically when there is not much of co-contracture. The ideal patient would be a patient who does not have significant retraction on attempted adduction or minimal upshoots or no upshoots, and abduction limitation close to -3. You could do a recess resect and get a good amount of improvement in the abduction and fix the ET and the face turn. So here we are trying to enlarge the field of binocular single vision in them, because we are resecting the lateral rectus also here. Okay. Now, but generally the resection of the lateral you shouldn't do more than I would say about 4 millimeters or 5 millimeters, not more than that, because again the creation of a leash when the eye tends to adduct on the same side. So this is one procedure which is done in select cases. Now you see here in this. This is the same picture which I showed you. We just did a left medial rectus recess, and you see significantly improved face turn, and also improvement of abduction. What happens in these Duane syndrome patients over a period of time, the medial rectus tends to undergo contracture and it becomes tighter. So you get little, once you release the tight medial rectus, you tend to improve the abduction by a certain amount on a scale of grade 1 to 2. Let's say from -4, it could go to -3. And that's a kind of a bonus to them because the goal was here to basically correct the head posture, but the goal was not to improve the abduction. Now, if you want to do kind of a procedure where you want to kind of enlarge the binocular single vision field, then you have to do a muscle transposition procedure. Either it could be vertical rectus transposition, or it could be just a superior rectus transposition. Now, back in a few years back when this VRT was done by Rosenbaum and colleagues, I think Pradeep Sharma knows it because Pradeep Sharma was with Rosenbaum for some time. So he might kind of recall the vertical rectus transposition was done for the Duane syndrome, esotropic Duane syndrome. They had significant improvement of head posture. No, not the head posture. Of course, head posture improved, and also the abduction improved in about 2/3 of the patient. But 1/3 of the patients in his series and Rosenbaum series, they also had vertical tropias, so which wasn't there before. So the downside of doing a vertical rectus transposition for esotropic Duane was that you tend to develop a hypertropia in about 1/3 of them. So that was one of the concern. So some people still do vertical rectus transposition. Subsequently, in the past 4 to 5 years, or maybe around 5 to 6 years, we have been kind of doing this procedure, what we call as a superior rectus transposition. Now, this is just one muscle transposition, and this tend to give a good effect of improvement in abduction. Either it could be done as an isolated procedure, or it could be clubbed with a medial rectus recess on the same side. So you get good amount of correction of the head posture and also improvement in abduction on a scale of -4 to -2. And if it's beyond that, it's definitely a bonus. So it's kind of an enlarged field of binocular single vision without creating any vertical tropias with just one muscle transposition, that is superior rectus transposition to lateral rectus. Now, what do you do alone? And a superior rectus transposition, the indication is basically if you have less than 15 prism diopters of esotropia with a head posture in a child, and on the forced action test, the medial rectus is not tight or mildly tight, then you do a superior rectus transposition alone. That would correct the esotropia, eliminate the head posture, and also improve the abduction. So it will kind of enhance the binocular single vision field in this child. Now, if you have an esotropia which is more than 15 prism diopters, let's say you have 20 to 25 prism diopters, then you have to add a medial rectus recess. That could be anywhere between 3.5 millimeters to 5 millimeters of recession of the medial rectus, depending on the primary position deviation. So it'll give good amount of abduction, improves abduction, reduces the ET and the face turn. So these are the procedures which have kind of worked well with. It started as single, 1 or 2 case series by different authors, and then kind of a few authors have clubbed in and put together the results. And I have done myself in my hands. It does really work well, but I don't augment. I don't augment the superior rectus transposition, but some people put an augmentation suture, a Foster's augmentation suture. Now, I haven't done vertical rectus transposition for a Duane syndrome esotropic, so I don't have much of an experience with VRTs. Now, there is a caveat here in superior rectus transposition. Sometimes in adult patients, if you are doing a superior rectus transposition, watch out for a torsional problem. Sometimes it can cause intorsion, significant intorsion to the patient, and the patient can complain of torsional double vision. So sometimes you may have to go and undo the superior rectus transposition, especially in adults. So you have to be very careful. Now, I just want to share this. So the superior rectus transfer to lateral rectus in Duane syndrome. You can see here, type 1 Duane with face turn, and very minimal or mild retraction, I would say, and no overshoot of the eye, and abduction limitation here, and ET in the primary position. this is post-op. This patient had about 25% diopters of esotropia in the primary position, and you see the primary position pretty much well aligned and markedly elevated head posture, or none, absolutely. And you can see significantly improved abduction, and much more as they tend to go into elevation as opposed to in straight lever version, and down gaze and in the side gaze. So basic thing is you shouldn't create a limitation here. If you do too much of surgery, and sometimes the phosphorus augmentation sometimes can give rise to an exotropia into this case, which the patient was actually not having before. So you have to be a little kind of judicious enough in it to not to create a double vision into the field of opposite field. Okay. So this is basically the superior rectus tendon transposition, single muscle transposition along with the medial rectus recess. That's what the esotropic Duane, but bilateral medial rectus recess for a larger angle, esotropia, or if it's a bilateral Duane syndrome, esotropic Duane, you have to do a bilateral esotropic, bilateral medial rectus recess. You could also do a bilateral superior rectus tendon transfer along with medial rectus recess in both eyes, like what you do for unilateral Duane. And few authors have done like that, and so they've shown good results. Now, coming to the exotropic Duane, this is the second most common, type of Duane syndrome. What we see, a paradoxical one. You have a limitation, in a sense, in Duane, in the type 2 Duane, you have a limited, kind of adduction, but minimal limitation of abduction. Sometimes there is no limitation, actually. In fact, the patient adopts a head posture, and you can actually see that the eye is abducting fully well, except for mild -1 limitation of abduction, but this limitation of adduction. And then, you have, these are the patients, the type 2 Duanes or the exotropic Duane, they tend to have severe upshoots, marked upshoots, and severe narrowing of the palpebral fissure and retraction of the globe when they adduct. So, and then they have a head posture to the other side. So this is a typical of exotropic. You can see here in this picture here, there's eye tries to adduct, this marked limitation adduction here, and then you see the narrowing of palpebral fissure there. Now, exotropic Duane, what do you do? The commonly recession of the lateral rectus, either unilateral or bilateral, depending on the amount of limitation which is there in the affected eye. If there is minimal limitation of the abduction in the affected eye, then you do less of recess. Then you do asymmetrical recession, again, depending on the amount of deviation what you have. So by and large, the lateral rectus recession is the preferred modality in unilateral Duane syndrome. Now, and as I told you, asymmetric recession, this is important because, if you do a large recession, you might worsen the abduction in that eye, in the affected eye. Previously, to start with, if there is a -2 limitation of abduction and you do larger recession, you will create a more amount of limitation. Or if -1 limitation is there, you're going to create more limitation by doing a larger recession. So you resort to asymmetric recession. So you do less recession in the affected eye, more recession in the contralateral eye, and then that helps to kind of make the eye straighter and also eliminate the head posture. So that's what the asymmetric lateral recession. So how does it work? Now, when you are recessing the lateral in the unaffected eye, this creates a fixation duress. So as a result of which you get more innervation to the medial rectus because of the Herring's law, and that more innervation to the medial rectus of the affected eye reduces the XT. So that's how it works. So you do a large recession, of the non-affected eye, non-involved lateral rectus, and less of the lateral rectus recession on the Duane's eye. So this will kind of balance the adductions in the Duane's eye and also helps to kind of maintain a good binocular single vision field and eliminate the head posture. Now, at the same time, we may have to add, another procedure because generally these type patients tend to have a lot of upshoot and downshoots. Then you have to do a Y splitting of lateral rectus, which I preferred, my preferred modality for that. Okay, but if you don't have much of a overshoot or retraction in them, you just do asymmetric lateral rectus recession. Now, mind you, tight fits are tighter. Generally, what happens is these exotropic Duane, they tend to come to you at a later stage in the life. By the time the whole of the orbital tissues on that side would have got contracted. You have tighter lateral rectus, bulkier lateral rectus. Most of the Duane's patients' muscles are bulkier. Bulkier in the sense that they are thicker in the diameter, and they're also pretty much tighter over a period of time. So tighter lateral rectus muscle will tend to give more effect of recession per millimeter. So this is pretty much, if it's less than 20 PD, you do one eye lateral rectus recess. But if it's more than 20 PD, then you do kind of asymmetric bilateral lateral rectus recession. Now, if you have a severe globe retraction because of a co-contraction, then you do a differential lateral rectus and medial rectus recession on the same eye. So, to take care of the retraction at the same time. And if you have an upshoot, a severe overshoot, then you do a Y splitting at the same time. So you recess the lateral, and then Y split like this, so that the globe, gets stabilized when the eye is moving up and down over the Y. Okay. So these are the additional procedures which you have to do when you have upshoot or significantly upshoot or severe globe retraction in an exotropic Duane syndrome. Now, bilateral XT Duane is again very, very rare. It's not commonly seen. Bilateral esotropic Duane is common than bilateral exotropic Duane. But here is a patient, child with a bilateral exotropic Duane. You see that the eye is trying to adduct, retraction of the globe, narrowing of the palpebral fissure, and again, when this try to adduct, you tend to get the it's there in this side picture. I think it's not being shown here. Okay. Anyway, now we did a bilateral lateral rectus recession, large recession in both with the bilateral Y split, and on the post-operative picture here looks good on the post-op day one. Now, this is some of the pictures which I wanted to share with you. As you all know, Duane syndrome patients tend to have accessory slips of bands or accessory fibrous band or accessory lateral recti slips, which are attached onto the globe. You can see these are not foot plates of the muscle. Foot plates of the muscle are attached to the muscle. These are not accessory slips. You see them. You can see actually they're attached here. This is the original insertion of the lateral rectus. And after the lateral rectus is disinserted, you see the small slip going backwards separately. Then you have to kind of release all this. Otherwise, your surgery will fail. Now, here we have done a Y split here. You see that. We have recessed the lateral. Original insertion is here. Recessed the lateral, Y split. And this Y split, both the arms of the Y will stabilize the eye as the eye goes up into elevation and depression and prevents the upshoot and downshoot. And that's how it works. This procedure was actually kind of propounded by Art Jampolsky long back. And then it went away. But subsequently, we started doing this more often, and we published a series of cases of Y split, eliminating the upshoot and downshoot and presented at the EPOS meeting and published subsequently in the EPOS journal way back in 2000s. Coming to another type of Duane, this is kind of a straight-eyed Duane. You can see here in the picture here, pretty much orthotropic. Sometimes you have type 1 Duane syndrome patients who are orthotropic too, in the sense that they have minimal esotropia or less than 5% diopter esotropia, no head posture, but they have abduction limitation, but they have a good adduction, minimal or mild inophthalmos or retraction. Those are some of them. Orthotropic Duanes can also be seen in type 1, where you don't really kind of intervene in them unless they want to kind of enlarge their binocular single field vision because they don't have head postures. Now, this is a type 3 Duane, or what we call a straight-eye Duane, where there is no head posture because primary position deviation is orthotropic, limited abduction and adduction, marked narrowing on adduction and inophthalmos retraction, and severe upshoot on adduction. And usually, sensory status is usually normal to maintain good binocular vision in the primary position. Now, you see this, typically, you see this marked upshoot there, limitation of abduction here, limitation of adduction, downshoot, upshoot, and straight eye here. And here we have to kind of do a lateral rectus recession and medial rectus recession, both recession of the lateral and the medial, the ipsilateral eye, to reduce the retraction of the globe and also the co-contracture, to reduce the co-contracture, effects of co-contracture. And you Y-split to take care of the upshoot. Now you see there's kind of markedly elevated upshoot here, and also the downshoot as the eye goes into adduction, as opposed to here, what you see here. So this is a type 3 Duane. Now, coming to the upshoot and downshoot, a little bit about upshoot and downshoot and hypothesis of this. With Jampolsky, way back in 1978 at one of the symposiums at New Orleans, they put forward a hypothesis, a leash effect of the tight lateral rectus. So as the eye is trying to adapt, because of the tight lateral rectus, as the eye is trying to adapt, it kind of tends to slip up and down, and that causes the kind of the upshoot and downshoot. Now, various modalities of treatment are there, like recession of the both horizontal recti, or sometimes some people have done a large recession of the lateral rectus muscle with lowering of the insertion, and posterior fixation suture, like Fardon of the horizontal recti, to take care of the upshoot and downshoot, and Y-splitting of the lateral. These are various modalities available, which people have tried before in the literature. But I think the posterior fixation suture is hard to do. Theoretically, it might work, but it's very hard to do in Duane syndrome patients because of the contracture on the lateral side of the orbit. And you know very well that if you have to put a Fardon on lateral rectus, you have to go way back to put. And it's extremely difficult to do a Fardon procedure in Duane syndrome patients. And of course, recession of both horizontal recti could help in a shorter term, but in the longer term, again, I think the upshoot would definitely come back. So probably, I think my bet would be, or because I've been doing it for years now, Y-splitting of lateral rectus, and it has worked well in my hands. So this was a unique idea propounded by Jampolsky way back, where you split the lateral rectus into two halves, and the two halves they stabilize the muscle position on the eye whenever the eye tends to move up and down, and prevents the eye to slip up or slip down. Now, in an article in 1984, Philip Diario, he said that since globe retraction is an attempted adduction is a concomitant part of the Duane syndrome, especially in patients who have tight lateral rectus muscle, it is always better to consider recessing the lateral rectus in addition to Y-splitting. Not only Y-split, but you also recess the lateral because it's it's a globe retraction and a tight lateral rectus muscle. It tends to help better. Now, this is just a cartoon to show you how it is, and the effectiveness of the Y depends on the restriction created by each of the two arms. As the patient tends to look above the midline in the adducted position, the upper arm rotates over the globe, and the lower arm is placed under tension. It contracts and prevents the eye slipping upwards. Same way, the eye when the eye is looking down below the midline, the lower arm kind of rotates over the globe, and the upper arm is placed under tension, and it contracts and prevents the eye from slipping downwards. So this is how it works, the Y-split. The procedure itself is relatively easy, and where you have to do split the lateral rectus up to 10 millimeters from the insertion, and then the muscle is resutured with upper half along the superior end of the insertion of the lateral rectus, and the lower half is along the inferior end. And if you are recessing it, just follow the configuration of the superior and the inferior poles of the lateral rectus. This is a short video. I think the video is not working here. I think I can show the video later. Okay.
Yes, sir.
I think let's go on to the next. I think I'll just open it and show it a little later. Okay. Yeah. Let's. Just to share with you some of the examples, as I told you already. Here's a small child, 5-year-old child with minimal head turn. I would say very kind of a micro or to, I think, looks orthotropic in the primary position, but you see here marked retraction of the globe, and severe upshoot there. And here you can't even see the eye. You can at least see the eye here downshoot. Okay. And so after doing the Y-split and both the recess lateral rectus and medial rectus recess, you see markedly elevated upshoot and downshoot. and pretty much cosmetically, appearing good to the child. Another patient here, you see, marked upshoot here. Upshoot is more than the downshoot here. And similarly, after doing a wide split and recessing both lateral and medial at the same time to kind of, eliminate the co-contracting effect of both co-contraction, effects of co-contracture, so that you can reduce the retraction of the globe. So wide splitting is a safe procedure and is extremely effective. And in patients who have marked globe retraction and also ocular deviation like esotropia or exotropia, you need to kind of additionally recess, especially when you have esotropia, you need to additionally recess the medial rectus in addition to the lateral rectus. So what are the limitations of treatment in Duane syndrome? Now, first and foremost thing, when you start treating them, I told you the indications when to treat and what are the limitations. The limitations, you need to tell the parents, what are the limitations? The parents think that your surgery is going to kind of improve the eye movement and make it normal. The first thing you should tell the parents that your eye movements will not become normal. The reductions in normal cannot be achieved fully, in spite of doing whatever you may. You can markedly reduce the overshoots, but sometimes you may not eliminate them totally. Because you might still, on a scale of, a 4 upshoot, you could reduce it to kind of -1, but sometimes you might still have a little upshoot and you can still have some amount of retraction, but you cannot totally eliminate them. So you can significantly improve it. Okay. Now, fusing patients will tend to have areas where they have double vision even after treatment. So you should tell them, otherwise some adults might complain that they're trying to see double when they try to look into side cases. So you should tell them that, you will tend to have double vision, which they had before also. Now, so basically the surgery is aimed to do these. One is to straighten the head posture, enhance the field of binocular single vision, lessen the overshoots, lessen the retraction, and reduce the unwanted effect of the co-contraction of the medial and the lateral rectus muscles. So these are basically the why the surgery is done and what is it aimed for. Okay. So that's in a nutshell, Duane's retraction syndrome. I haven't gone into synergistic divergence. That's a rare thing. Plus, I haven't talked about some of the resurgeries in Duane syndrome, but I think this is pretty much what I do myself, and I think it should be helpful to a lot of people who see Duane's patients quite often in their practice. So I thank you all for giving me the opportunity to speak on the eye focus. It's been a while. I haven't been on the eye focus for some time. I did before a few years back when it was, not virtual. Yeah.
Thank you so much, sir. Thank you so much for your valuable time to spend the evening with us and educating our residents with that excellent talk. Pradeep Sharma, sir, Amitava, sir, before we go on to the questions, any remarks from you?
Yeah, I think it was a wonderful talk with very practical points. As we all know, Duane's retraction syndrome is a condition which has to be individualized treatment has to be done. Each case has to be considered differently. There are certain points which I would just like to add. One is about the etiopathogenesis of Duane's retraction syndrome. And this I would like to highlight from the point of view that maybe in future we may be able to prevent Duane's retraction syndrome, because there is a very nice article by Parsa and Robert in JAMA 2013, when he described that what we know that it usually occurs because of some disturbance in the 6 to 8 weeks of antenatal period. And the cause that has been found out is probably higher estrogen and inflammation in the veins. So it's a venous thromboembolic phenomenon which is causing in this 6 to 8 week period. And the causative agents could be misoprostol, which is being used as an abortifacient in some people, and some other drugs also, or sometimes even a viral fever. So the important point which is highlighted is that, which also in a way tells us why it affects more often the females. Like Dr. Rao was suggesting that the studies show that about 2/3 of the patients are going to be females, and there is a left preponderance compared to the right. Again, about 2/3 or 70% cases are left. So this is, I think, very nicely explained by his theory that it is a higher estrogen which causes more in the females, and it's the inflammation which is causing, and there is a right to left shunting problem which is there. So that is the reason why it's affecting more of the left side. So the lesson to be taken from this is that one, we should try to see these events, the thromboembolic events can be prevented in 6 to 8 week period. It may be some fevers, it may be nutritional problems which are in these ladies, or these agents like the misoprostol and all, which has also been shown by Miller's work in, I think, Argentina and Brazil, when they did that it is causing that. So that's one point I would like to highlight. The second is that majority of these are sporadic. 80% of these cases are sporadic, but 20% are known to be having genetic influences. And now we are also more and more going to be learning about the genes which are affecting it. So there are several of them. So from the postgraduate point of view, that also should be kept in mind, that there would be 20% cases which are mostly bilateral, or if there is a genetic history, then one should go for gene studies in these cases. The syndromes is another thing from the PG point of view, that we all may be knowing that golden heart syndrome is the most common one. Then there is a Klippel-Field syndrome, a Wilder-Wang syndrome, which also has deafness along with the kidney problem. And then there are other syndromes like the Holt-Oram syndrome, the Okehiro syndrome. So these may be from the PG point of view, that Duane's retraction syndrome would be a fellow traveler in many of these syndromes. The fact that it is a part of CCDD, or a congenital cranial disinnervation disorder, in a way also brings into the fact that it's a rainbow of several conditions. So Duane's is one of that. And as Dr. Venkat was saying, that the synergistic divergence, some people describe it as type 4, but basically it's a continuum of the same rainbow. There are several conditions which may be involved as congenital cranial disinnervation disorders. So this is like some points. As far as management is concerned, there is, as I said, it has to be done more of a individualized thing. And the important point to remember in Duane's retraction syndrome management is most of these conditions, the cases have binocular vision. The fact that they have an abnormal head posture, it is to retain or maintain that binocular vision. So the challenge in managing these cases is to retain the binocular vision. So that is important. It's unlike any esotropia or a sixth nerve palsy in an early phase in which binocular vision would have been already compromised. Here the binocular vision is preserved. So whatever you're doing, you have to ensure that binocular vision is maintained. So it may be kept in mind whenever we are dealing with Duane's retraction syndrome. And from the clinical point of view, we usually nowadays classify into ESO-DRS, EXO-DRS, and Ortho-DRS. So I think Dr. Venkat was trying to describe the management in these three subdivisions, that ESO-DRS cases, we have to basically correct the ESO in the primary position, but primarily also see that the basic problem is with the lateral rectus, which is having a paradoxic innervation. So in ESO-DRS cases which do not have too much of upshoot and downshoot, that are not severe retraction, may be just managed with a simple medial rectus recession. But here it's important to remember the medial rectus recession has to be the least required as per the FDT requires. If you do a little more, it will cause a synergistic divergence and iatrogenic synergistic divergence cases in ESO-DRS. So whenever you have a little more co-contraction than what you think is going to be there, then it has to be balanced with a lateral rectus recession. So differential recession of medial and lateral rectus is required in ESO-DRS cases which have more severe co-contraction. In all cases of ortho-DRS, a differential MR and LR has to be done. But nowadays we are telling that MR recession should not be done in EXO-DRS cases. In the older descriptions, it was even in EXO-DRS, there were some people would be doing a medial rectus recession. I think Jampolsky's article in Rosenbaum's book very clearly shows that it is actually wasteful of the anterior segment circulation of doing an MR recession. You may actually have to do MR resection in some cases in order to correct the residual exo, but MR recession is really not required in cases of EXO-DRS. So that is a point which I would like to highlight or emphasize. Regarding the transpositioning procedures, which Dr. Venkat was describing, so there are several of them. The superior rectus transposition, inferior rectus transposition, alone, or maybe both vertical rectus transposition. That means full VRT or a partial VRT. So to prevent anti-segment circulation problems, we are usually either choosing just one muscle, that means SRT or IRT, or a partial VRT. There is a nice article by Dr. Wells, which says that when you have a pre-operative vertical deviation, like if you have already a hypotropia in pre-existent, then SRT may be a better choice. If you have a pre-existent hyper, then IRT would be a better choice. But if you do not have any vertical deviation, a partial VRT would be a better choice. And now that has been replaced by mostly a Nishida's procedure. That means we do not have to disinsert the vertical recti at all. We'll just use the superior or the inferior recti belly transfers. So these are certain points which I would like to make. Dr. Amitava? You're muted.
Yeah.
Dr. Amitava, you're muted.
Yeah, I'm so sorry, sir. Thank you. Just two small things. One is that it's also important to, counseling is very important because, there's not complete expectation that Dr. Venkat pointed out. But two other things is, one is that in children particularly, it may be a good idea to discuss it with the teacher and the parent that they can sit in a preferred side of the class. For example, if they have a preferential gaze to the right, they may sit where the board and the teachers is to the right. Because in India now, I've realized everybody's switching chairs all the time. This child perhaps should be given the chance to sit on the favored side. That's one. And I like to tell my patients that one way to not show so much narrowing and widening is to have what I call as the table fan maneuver. That means if somebody is calling you from this side, instead of moving your eyes in that direction, you move the head perhaps. It can kind of cut down on some of the obvious retraction and widening that may take place.
All right. So I'll move on to the questions. The first one is, can you please explain the bridle effect again? The bridle effect, sir.
Yeah, me. You're asking me?
Why splitting the bridle effect, upshoots and downshoots?
Yeah. So basically, what happens is when the eye is trying to adduct against the tight lateral rectus muscle, when the eye is trying to adduct, because of the leash effect, suddenly, if it's in a position when the eye is elevating, suddenly the muscle slips over the globe and the eye shoots up. Okay. Same way it shoots down because of the tight lateral. At the same time, there is co-contracting which is happening, and then it slips up and down. Okay, that's the bridle effect. Okay, and that's what Jampolsky described at that time. So what we have done is when you Y-split it, you are creating a two arms in a Y-like thing. So the eye is going up or down. Either of the arm will support it, and the other arm contracts, and it prevents the eye to slip up or down. That's how it works.
I think was pretty clear. Next question is, how do we differentiate upshoot or downshoot of globe in DRS versus other causes?
Typically, the upshoot, you see a lot of times people get confused with inferior oblique overaction. Okay, it's not inferior oblique overaction. Okay, see, if you have just an upshoot, sometimes people can get confused with inferior oblique overaction. But as the eye is trying to adduct, it suddenly shoots up. Now, inferior oblique overaction is as it goes into adduction, it slowly elevates up in adduction. Okay. Now you also have a hypertropia. Okay. Now sometimes you want to see look into the fundus to see whether it's an oblique muscle dysfunction. If it's an inferior oblique overaction, if you're confused, you see there won't be any torsion when you have upshoot. Okay. So there's no oblique muscle dysfunction there. I haven't seen I never did any oblique surgery. For a Duane syndrome, people have said that, sometimes there could be oblique muscle overaction and people have done inferior oblique surgeries, but I haven't done anything in the last 20 years. And pretty much, the Y-splitting does work very well.
So basically, the shifting or slippage is happening depending upon the primary position of the globe, whether it's a hyper or hypo. So if you take the eyeball straight up and then ask him to adduct, there will be always a slippage or upshoot or upward slippage. If you take the eye down and then ask to adduct, there will be a downshoot. Now, if this is one simple test that will differentiate inferior oblique overaction versus, because in inferior oblique overaction, there won't be a downshoot. So you make the eye down and then ask him to adduct. If there is a downshoot happening, it is a sure sign that, okay, it's basically the slippage which is happening, upshoot and downshoot is also there. But you have to take the eye a little down, because many a times, if the eye is already having a little hyperposition, it will always show an upshoot and not a downshoot. So that is one way of differentiating. Second would be the primary position. If you have a large hyper and more so becoming much more in adduction, but also an extorsion, as Dr. Venkat was saying, look into the fundus. Presence of an extorsion is again a sure sign of an inferior oblique overaction, whereas the upshoots and downshoots do not have any intorsion or extorsion. But we have some cases in which we had to do inferior oblique weakening also when we found there was an extorsion. So if there is an extorsion, you may have to do the inferior oblique weakening along with this Y split of the lateral rectus.
Yeah, that's right.
So the next one is, in DRS cases presenting with retraction of the globe apart from a tight rectus muscle, is it possible to find anomalous insertion of other muscles?
I think he mentioned.
You can have vertical retraction. Sometimes it's been said co-contracture of the vertical recti can give rise to people have described recession of the vertical rectus muscles to kind of take care of the retraction of the globe. Again, a co-contracture. As the eye is going into abduction, there's a firing of superior rectus, and then the eye tends to go vertically up and causes retraction. Sometimes it's vertical retraction. People have described, but I haven't done any vertical rectus recession for any retraction so far, but people have described that, and people have done some surgeries like that. Was that the question?
So in DRS cases presenting with retraction of the globe apart from a tight rectus muscle, is it possible to find anomalous insertion of the muscles?
Anomalous insertion of the muscle? No, muscle would be, I haven't seen any anomalous insertion as such, but I've seen most of these Duane's muscles, either the lateral or the medial, they are wide. They are bulky, wide, and tight, extremely tight. Okay, but I've seen a lot of times accessory slips under the lateral, under the muscles. Accessory usually under the lateral rectus muscle. Accessory slip of you call it as an accessory lateral rectus slip, which is and which is attached about 4 or 5 millimeters behind the lateral rectus. And if you do not search for it, you will miss it. Once you disinsert the muscle, use your small hook and try to or use an iris spatula and try to see on the sclera. And sometimes you see this thin film, like what we see the superior oblique tendon, when we are actually hooking the superior oblique tendon on the temporal side. It's a glistening thing. Sometimes you miss them. And once you lift it up and you see that slip goes back into the orbit and it's separate from the lateral rectus. These are not the foot plates. So, but these are some of the, and you can see fibrous bands too, accessory fibrous bands. And so these are, but I haven't seen anomalous insertion of the muscle. I haven't seen that.
Pradeep sir, Amitava sir, any comments from you?
No, I don't have any comments.
Accessory slips are actually abnormal insertions, and one should be careful if you've done an FDT and then once you have disinserted the muscle, you still find that there is a tightness, then you look for these accessory attachments which are there. So that should be kept in mind, as Dr. Venkat has mentioned very graphically, that you should always make sure that these accessory attachments are taken care of. Otherwise, you will have a failure in your surgery.
The next one is, how do we differentiate between abduction limitation in DRS versus sixth nerve palsy?
Yeah, that's pretty much. Abduction limitation in sixth nerve and the Duane's would be the same. What you need to see is looking at the deviation. If you have a sixth nerve palsy, you have a larger deviation.
Okay.
And you have a larger esotropia. Whereas in a Duane syndrome, the deviation doesn't commensurate with the amount of the abduction limitation. You have a -4 abduction limitation, but you have only 15 prism diopters of esotropia. Okay, that should click. That should tell you that this is nothing but Duane syndrome. Sometimes you may not have a narrowing of the fissure, which could be subtle retraction could be there. You could miss it, but one thing is the deviation per se. Now, other thing would be abduction limitation, and you have a small exo, which is paradoxical. And that's clear-cut Duane syndrome. Nothing else can be there. So that's how you need to looking at, apart from the other features, what you see.
I'll go on to the last question for the day. How do we decide on the extent of MR recession to be done in these cases? And can you please explain about the fixation duress?
Yeah. See, the amount of recession, what we do is depends on the amount of deviation. Generally, it's about if you take 20 prism diopter of esotropia, I think one muscle surgery on the same affected eye would take care of it. Like about 5 millimeters to 5.5 millimeter recession of the medial rectus on the same side for 20 prism diopters of esotropia would help you to kind of take care of the primary position, straighten the eyes in the primary position, and also kind of markedly improve the head posture. And if it's a tighter muscle, if it's a tight muscle, then you may get some amount of improvement in abduction too. That's with a 20% diopter of esotropia. Now, if you have a larger esotropia, then you have to kind of do either you do superior rectus tendon transfer, superior rectus transposition along with medial rectus recession, or you do contralateral medial rectus recess. So what happens when you do contralateral medial rectus recess is you could do a larger medial rectus recess. So you need to create a fixation duress on the unaffected side. That means you are weakening the unaffected side, the right medial rectus, a large recession. So when the eye tends to move into the field of action, it's weakened. Okay, so it's the duress, which the fixation duress, it tends to kind of get more innervation to the affected lateral or the left lateral rectus. So the left lateral rectus tend to get more innervation. At the same time, the medial rectus on the other side, according to the Sherrington's thing, gets inhibited. So you get, so that's how it works. So other eye medial rectus gets inhibited by doing the contralateral medial rectus recession, creating a fixation duress, and so you get lesser ET and less amount of medial rectus, firing on that side, and the medial rectus doesn't go into contracture over a period of time. That's how it works. The same way the lateral rectus, the bilateral lateral rectus recession works too. You do a larger lateral rectus recess in exotropic Duane. If let's say right exotropic Duane is there, you do a smaller recession on the right side, do a larger recession on the right lateral rectus, create a fixation duress, and so that your thing gets corrected. It's exactly the same opposite to what we do on the esotropic Duane.
Actually, by definition, as Dr. Venkat was saying, the ocular deviation and the limitations are not going to be proportionately there. The same way, the medial rectus recession surgery has no direct proportional effect on the deviation, and it should not be done that way. Because in an ESO-DRS, if there is a marked upshoot and downshoot, if you do a little more recession of MR, you would have a synergistic divergence. So this is something to be kept in mind. If you have a larger ESO and you have a marked upshoot, still you would do less MR recession. For more effect, you would have to do the other MR, the normal eye MR, in order to correct the larger esotropia. Just because you have a larger esotropia doesn't mean that you will do a larger MR recession in cases of Duane's retraction syndrome. So that should be kept in mind. And you will have to balance it if there is a large upshoot and downshoot. Any ESO, the MR recession that you're doing with an LR recession in order to prevent this synergistic divergence. And as I said earlier, MR recession is not required to be done in exo-DRS at all. So there is no role of doing an MR recession in exo-DRS. The main culprit in Duane's retraction syndrome is the paradoxic innervation of the lateral rectus. The MR is actually having the suffering, it's a victim of the problem. So many times, ESO-DRS cases, you might even have an adduction limitation because of the co-contraction. The lateral rectus is not allowing the eye to adduct because of the co-contraction in adduction. In that case, the culprit is lateral rectus and not the MR. So, I mean, you have to keep these things in mind, that there is no thing like if you have a larger esotropia, I will do more MR recession. You would have to be doing the least amount of MR recession as required by the tightness of the medial rectus. It's the FDT which decides the MR recession in Duane's retraction syndrome, not the esotropia in primary position. And if it is more esotropic, sometimes it means you would have to do the other eye MR recession, a contralateral MR recession, which will also have a fixation duress effect.
So with this, we come to the end of our session for today. Amitava sir, final, any take-home message for our viewers? One take-home message, one pearl.
Okay, so what I normally do, so there will always be time. There is a little bit of science and a little bit of art of surgery here. So sometimes it is better to stagger these surgeries. I mean, you don't have to do the entire thing at one go. If you have doubts and if you think that I'm not sure if my medial rectus would be enough, then it's fine to go ahead with the medial rectus and then follow it on with a second surgery. It doesn't have to be done in the same setting. That might help to because students are actually, postgraduates, looking for numbers, those magical numbers. They think they're there in some of these Squint tables. The Squint tables don't work here.
Yeah, absolutely right. Yeah.
Thank you so much, B Rao sir, for spending the evening with us, educating us on this such an important topic for all the postgraduates. So with this, we come to the end of our session. Pradeep sir, concluding remarks from you.
I think I would just like to thank you, Shefali, for anchoring this session so nicely, for bringing out all the points of queries from the various people. And thanks, Dr. Venkat, for giving your time for this talk on the Duane's retraction syndrome. Thank you, Dr. Amitava. And once again, I would like to thank Dr. Santosh for giving us this opportunity of having this iFocus online on strabismus. And thanks to the audience for their interest in it, which I am very happy to note that it's increasing every time. I mean, it's going into, now it's gone like 1 million viewership for the cases of iFocus. So it's a real boost for all the teachers. The best thing the teachers want is the students should be interested in learning. Thank you all.
Thank you.
So next, we'll meet on the coming Friday, which is September 23rd. The topic is Brown syndrome, the etiology, associated anomalies, diagnosis and management, and adherence syndrome by Dr. Manjula Jayakumar. So see you all coming Friday. Good night, everyone.
Thank you.
Bye-bye.
Thank you, Dr. Pradeep. Thank you, Amitava. Thanks.